Good afternoon, and thank you for inviting me to speak on the impact of respiratory conditions on maternal health in the online symposium series on maternal health and innovation, advances in research and technology, organized by the Gangwal School of Medical Sciences and Technology, IIT Kanpur. I am Dr. Ritu Kulshrestha. I am the Director Professor and I head the Department of Pathology at Vallabhbhai Patel Chess Institute. So maternal health in India is reflected by the maternal mortality rate. And while the MMR or the maternal mortality rate has seen a drop from 212 deaths per 1 lakh live births in 2007 to 2009 period to 113 in 2016 and 2018 period. The present maternal mortality rate is currently stands at 93 per 1 lakh live births as of 2025. While this figure indicates a significant improvement from previous years and reflects a progress in the maternal health initiatives, however, the maternal mortality rate remains above the sustainable development goal targets of less than 70 per 1 lakh live births, highlighting the need for continued efforts to enhance healthcare access and maternal health services across the country. I will be taking this in talk in 5 key areas. One is normal respiratory physiology, physiological changes during pregnancy, labor, postnatal period with respiratory effects, the pre-existing maternal respiratory diseases that can affect respiratory pathophysiology and pregnancy, potential complications to the newborn, and the research ongoing and the vaccine development in this area, which are very important. So the maternal physiological changes occur as a result of anatomical changes and hormonal changes, and together there is the expanding uterus of pregnancy causes an elevation of the diaphragm and progressively impacts the oxygen reserves and gas exchanges. Along with the changes in the hormones, the progesterone and estrogen, and the relaxin, which loosens the ligaments and cartilage and allows for the expansion of the rib cage, there is a gradual expansion and increase in the anterior posterior diameter of the rib cage. There's an increase in the transverse diameter of the rib cage, and there is a change in the subcostal angle as the subcostal angle increases and the ribs rise. All these two together result in the physiological changes, which in each trimester can result in progressive breathlessness and is referred to as the dyspnea of pregnancy. If we see the spirometry, then as compared to the spirometry of a normal individual here, of a non-pregnant individual, where the total lung capacity is 4,200 ml, and the vital capacity, which comprises of a vital capacity of 3,200, an inspiratory capacity of which is 2,500, a tidal volume of 450, and a functional residual capacity of 1,700. The rising diaphragm, which is seen in a gravida at term, results in, while the total lung capacity remains similar, there is an increase in the tidal volume from 450, which we have seen here, to 600. There is an increase in the vital capacity, while the vital capacity remains same. There is an increase in the inspiratory capacity to 2650. And all this is needed because an increased oxygen consumption of approximately 20% is needed to maintain the metabolic demands of the maternal and the fetal tissue. To compensate for this increased tidal volume, which we have just seen, increases by 15 to 20%. The total lung capacity remains the same, 4,200 to 4,000, but the functional residual capacity reduces. This reduction in the functional residual capacity lowers the carbon dioxide concentration. It increases the arterial pH. It results in a state of compensatory respiratory alkalosis, which results in physiological dyspnea and should be distinguished from additional or pre-existing cardiopulmonary diseases. There are several pre-existing maternal respiratory diseases which can worsen during pregnancy. And prominent among these include asthma, respiratory infections, pneumonia, pulmonary embolism, cystic fibrosis, interstitial lung diseases, and COPD. Some actionable strategies for these pre-existing maternal diseases include their early identification by strengthening the antenatal screening for respiratory conditions such as asthma, tuberculosis, COPD, improving vaccination coverage for influenza, COVID-19, pertussis to prevent respiratory infections, enhancing access to oxygen therapy and intensive care in maternal health facilities, especially in cases who are suspected to have interstitial lung diseases or diffuse parenchymal lung diseases. And finally, to reduce the environmental air pollution by promoting clean cooking fuels and reducing the tobacco smoke exposure. Air pollution not only does have effect on the maternal health, it also can affect the unborn fetus and child. This exposure comes from tobacco, from chula smoke exposure. It can come from environmental smoke, from occupational exposure, and last but not the least, from climate change. Now, what happens when the mother is inhaling particulate matter, which is PM10, PM2.5, or PM1? As the size of the particulate matter decreases, its deposition into the lung, it starts invading into the lung and the deeper areas of the lung tissue. It affects the alveoli. It can reduce the lung function. It can give rise to airway damage and asthma. And all this is because of the oxidative stress, the reactive oxygen species that result in the progressive airway remodeling and fibrosis. There is a lot of immunopathology going on at this time, wherein the allergens which are inhaled cause the Th2 cytokine reaction and inflammation, and eventually the genes related to oxidative stress can affect fetal growth by involving the mitochondrial function and inflammation. Such children present as intrauterine growth retardation, or IUGR, preterm birth, low birth weight, reduced lung function. And therefore, climate change and the global climate crisis is proving to be the defining challenge of our era, where the climate change driven environmental factors such as air pollution and temperature extremes not only affect the maternal respiratory health, they lead to reproductive health outcomes such as reduced fertility, miscarriage, preterm birth, and congenital abnormalities. We all know that while climate change recognizes no borders, but the causes and consequences are not shared equally. And the most vulnerable countries lie between the tropics of Cancer and Capricorn. This is the Tropic of Cancer and Capricorn. And sadly, India, Africa, and the global south are the ones which are affected. Now, climate change, how does it give rise to asthma and pneumonia? It causes change in the weather and variability, affects the levels of heat and humidity, worsens the air quality, changes the composition, production, and spread of aeroallogens, reduces the survival and reproduction and distribution of pathogens, causing respiratory infections. Pneumonia in pregnancy can be more virulent with increased mortality, and pneumonia can exacerbate pregnancy-related complications like preeclampsia, gestational hypertension, and indirectly increasing maternal mortality risk. So together, the infections and the aeroallergens will not only precipitate asthma, but they can give rise to increased mortality and morbidity of the mother, also increasing the maternal mortality ratio. Another important condition which is contributing to fatality during pregnancy is pulmonary embolism. Now here you can see this is a picture of how the gravid uterus is sitting on the pelvic veins, and if there is stasis, if there is vascular damage, if there is a hypercoagulable state, then mm, sorry this can predispose to a formation of a thrombus, and deep vein thrombosis arises. And if this thrombus or DVT of pregnancy manifest as leg swelling, which can be unilateral. But if from the lower veins, if it goes up to the lungs, then it can give rise to dyspnea, palpitations, pain, and the mother can collapse and even death can occur. So there are key pathways which link respiratory health and with the maternal mortality rate. These include infections such as tuberculosis and pneumonia, non-infectious conditions such as asthma and pulmonary embolism, environmental factors such as air pollution, indoor smoke exposure, biomass fuel gas exposure, and emerging threats like climate change and COVID-19, which highlight how these respiratory infections can sharply increase the maternal mortality, especially in the unvaccinated populations. Therefore, there is a lot of work now and focus which is on the role of engineered biomaterials for mucosal vaccination to prevent the infections in the mother and prevent from pathogens such as the coronavirus, the Mycobacterium tuberculosis. However, the cruciality of how this mucosal vaccines will penetrate the mucosal layer and reach the target tissue are what is needed to be focused upon. And material-based strategies are being discovered to meet these requirements, and they are being investigated. Some of the routes of vaccination which are being studied include the intranasal, the oral, the pulmonary route, and the transcutaneous, where it can be intradermal, subcutaneous, or intramuscular route. And some of the vehicles which are being studied for vaccine delivery include the lipid-based nano carriers such as the liposomes, the natural polymers such as chitosan, beta-glucans, synthetic polymer-based synthetic carriers like the polymers and the polymer lipid hybrids, inorganic carriers like gold and silver, pathogen imparted carriers, and few devices here are shown where they are being investigated to deliver vaccines to the mucosa. So in conclusion, I'd like to summarize and say that maternal respiratory health is critical determinant of maternal mortality rate. Addressing maternal respiratory illnesses through preventive care and early diagnosis of maternal respiratory illnesses can substantially reduce the maternal mortality rate. And some of the preventive measures here have been described of hand washing, avoiding smoking, good ventilation, regular exercise, healthy diet, respiratory hygiene, or a spirometer, which can be done to improve the lung function, especially in those mothers who have got some pre-existing illnesses. With this, we can hope to improve the respiratory health of the mother. And I thank you for your patient hearing. And this is my institute, the Vallabhbhai Patel Chess Institute from the University of Delhi. And I thank you.